A genetic counselor is someone who works with families who have a family history of a genetic disease or a person who has suspicion of a genetic disease. We help with risk assessment and helping with finding what the diagnosis is for that person or for the family. Usually we work with, or a lot of times we work with a medical doctor alongside. We coordinate and help decide what testing should be ordered for genetic diseases or hereditary diseases. And we are trained to interpret those test results so that it's meaningful for the patient and for their family members, and be able to offer recommendations for screening or for management or testing for other family members based on what we find in a family. Well, since I work mostly in oncology, I work in cancer genetics almost exclusively now. My typical session starts with me coming in and introducing myself and talking a little bit about the type of cancer that person has had and what their history is, because we need to find out what features they may have that could be consistent with a hereditary syndrome of some kind. And I explain a little bit of why they're there and why their doctor may have thought that this was relevant for them, because a lot of times patients come in and this is another appointment on the list of things that they were asked to do as part of their cancer treatment or as part of their management. And so I explain a little bit what we're going to talk about, which is that we're going to take a family history, and then we're going to discuss maybe a genetic test if it's indicated, and that we'll talk about how that will have implications for themselves and their family. And then after doing the family history, I go through what features of the family might be indicative of a hereditary cancer syndrome of some kind. For example, if a woman has breast cancer at a young age, she may have family members who had breast cancer or ovarian cancer, and I'm sure to get what ages people were and what they were diagnosed with and what the pattern in the family is. And then after that, based on certain criteria, based on if she meets qualifications, we may recommend that she have a genetic test that could tell us whether or not there's a hereditary factor that was contributing to her breast cancer, and then we'll discuss whether or not how likely it is that we would find a genetic factor, and then we can go forward with doing the testing. We go through the risks and limitations of testing, including things like genetic discrimination and insurance issues, and let her ask us any questions that she has. And once we ultimately usually do the test in the office, we can do a saliva sample or a blood sample. We send that off, and typically we call our patients with results in the next couple of weeks and follow up with them based on what the results are. Genetic testing for breast cancer susceptibility or hereditary susceptibility is important not for everybody. So these kind of tests are not right for every person diagnosed with breast cancer. But if a person has the specific features or has the family history that is consistent or suggestive of a hereditary predisposition, testing can really provide useful, very useful information about what that person's risks for a future cancer are. Also, beyond just what their personal risks are, it can provide their family members with advanced warning of what they might be at risk for. Depending on the situation, and there may be other women in the family that could have preventive treatments or at least surveillance earlier than what they would have ever had normally, just given their family history. A genetic test might be able to clarify who in the family is at risk versus who in the family is not. So, just an example is if you have a gene mutation that could be passed on to two daughters, say I have a BRCA mutation and I have two daughters, it's very important for me to know if I have a BRCA mutation, because by knowing that information, both of my daughters can get tested for that particular gene mutation and find out whether they inherited it, because they had a 50% risk. The benefits of the testing is that if one of them tests negative, or both of them test negative possibly, then neither of them need to be doing all of these high-risk enhanced screenings and think about risk reduction options, barring other medical problems. But they don't need to be doing all of that because they didn't inherit the high risk factor that I had, right? Alternatively, if they actually did inherit it by finding out through a genetic test, then they would be qualified to do all of those things, and all of those things would be available for options for them. So it really allows us to do risk stratification for women within a family where we know what's going on genetically. So that's why it's very important for a woman or a person, anybody who has a family history or themselves is suggestive of a hereditary syndrome, to get tested. Hereditary breast and ovarian cancer syndrome is a hereditary predisposition to cancer that is caused by inherited gene mutations in most commonly BRCA1 and BRCA2. These are genes that everybody has. We all have 2 copies of each one of these genes, BRCA1 and BRCA2, in every single cell of our body. Some people, rarely, have a faulty copy or a mutation, we call it, in either one copy of the BRCA1 gene or one copy of the BRCA2 gene. And that faulty copy or mutation was inherited from one side of their family, either their mom's side or their dad's side. And it puts them at elevated risk for the development, particularly of breast cancer. Women with a BRCA mutation have up to an 80% risk for developing breast cancer. Also ovarian cancer, up to 40% risk for ovarian cancer. The numbers are variable, may depend on the gene, may depend on the study that you cite. But also women who've already had a breast cancer are at much increased risk for development of a second breast cancer. And so that's why we may recommend, or the woman may opt to have more aggressive surgery if we were to find that she had a BRCA1 or 2 mutation even after she's already had breast cancer. Like I said, these are inherited in a family. If somebody's found to have a BRCA1 or a BRCA2 mutation, each one of their children has a 50% chance of having inherited that mutation from that person. Also, the person who has a BRCA mutation would have their siblings, whether male or female, would have a 50% chance of having one of these gene mutations that causes this hereditary predisposition to these cancers. Men don't have as high of risks associated with BRCA. They do have risks. There's male breast cancer seen in some carriers, and also prostate cancer is at a higher incidence. And we can see pancreatic cancer and some other cancers in families with BRCA, but those aren't necessarily the hallmarks. We see mostly breast and ovarian cancer. The way that we used to do things was that we would order, for cancer genetics, a young woman would come in with breast cancer. The way we used to do it is that we'd order the BRCA1, the BRCA2 together. Sometimes we'd have to order an additional test as part of the BRCA genes that looks at rearrangements in the genes, but still needed to complete the whole package. So that would be, one test, we'd wait 3 weeks, another test, wait 2 weeks. Then if the family history was particularly strong, maybe we would order another test and it would look at another gene and then another gene. That process could go on for a long time, and we have a lot of genetic information, right? That was the traditional sequencing, the way we did it with traditional sequencing, looking at one gene at a time. The next generation panels, the benefit of those is really that we can order a test, one shot, that looks at not just the main 2, the BRCA1 and 2, includes that rearrangement extra part that we often order. And it also includes all of these other genes that we would have kind of gone stepwise through, and it really would have lengthened the odyssey, or the diagnostic odyssey, for the patient and for the management team. One of the best benefits about these panels is that we can kind of mix and match what we need a little bit, and there's several different panels that Ambry offers. One for breast cancer that looks at the 16 different genes, that's the big nextgen panel, but then there's also a smaller one for, I believe, 6 different genes that are very high risk gene panel that actually turnaround time is the same or similar to the BRCA genes. So we really got the advantage of next-gen sequencing without having to wait the long length of time for the largest panel that they offer. So that's a benefit to doing the next generation sequencing, and I think that's really attractive to the patients, and it's really helpful for us as genetic counselors. So they have this really great policy where they will contact me if there's any out-of-pocket cost for the patient that exceeds $100. So there's a pretty low risk, especially if the patient does meet criteria that we looked at beforehand, and we send it off. And once it goes through their insurance verification process, if it goes through that, we can pretty much tell the patient that they're not going to have a bill of thousands of dollars for one of these tests. So that's really great on the patient's side, because they're always, the question that I get is, am I going to get a bill for $4,000? I heard that this test costs $4,000. And you know, we can be very reassuring, especially when we're working with Ambry, that we know that even if something happens in an error, that that we'll be able to work with the laboratory to make sure that the patients and the genetic counselors are all on the same page about how much the test costs and what the patient will owe if they do. Just recently, we had a case where a young woman, unfortunately, came in with a diagnosis of breast cancer, a recent diagnosis of breast cancer. This was a couple months ago, and she really, given her age of diagnosis, and she had an extensive history of pancreatic cancer as well, we really weren't sure what to order for her. And we knew that she was going to be pending surgical decisions. So she was going to be deciding whether or not to treat her breast cancer by removing just a part of the breast, which is kind of the standard treatment for a local breast cancer, or if she would be doing something more dramatic, like having both of her breasts removed, because of a concern about a risk for a future breast cancer. So she came to us saying, I'm trying to decide between these two alternatives, and I really want to know if I have some kind of hereditary or genetic susceptibility that led to my cancer, so that I could make the most informed decision, because women that have a hereditary form of breast cancer are more likely to get another breast cancer in the future. So we, at that time, went ahead and ordered. Normally, or in the past, we would have just ordered the standard BRCA1 and BRCA2 genetic tests for her, because that was the standard of care up until really recently. But the benefits now are that we can, especially with Ambry's new tests, we can order a panel that looks at almost all the genes that we know of, not quite all, but almost all the genes that we know of that can contribute to early age of onset of breast cancer and a strong family history of breast cancer or other cancers. And those other genes outside of BRCA1 and BRCA2 can account for a significant portion of these families, even though individually each one of those gene mutations that we find are going to be rare. So she went ahead and did that panel test instead of just going for the stepwise procedure, and they actually found a gene mutation in one of the other genes, the non-BRCA genes, which really, she was thinking, when we met with her the second time, we met with her to talk about the results of the test. That result really led her in a direction that said, okay, I am in a higher risk category. I think that I want to go forward with what we were kind of thinking about before of being more preventive and proactive about bilateral mastectomy. Also, it may or may not have, or it may have an impact on her treatment, as far as her radiation exposure and things like that. So that was a really good way that we used the panel, and it returned us results in time, and we were able to use it, and the patient felt like this was information that her and her family could use. Additionally, the family history was consistent with what we found, and so we were able to, we're still in the process of discussing with the family whether or not they want to get genetic testing to find out who's a carrier of the same gene mutation, and if they would qualify for any early enhanced screening based on these results. Women that test positive can opt for surveillance of the breast tissue through MRI and mammography, or they can take other options, like there's what we call chemoprevention. There's drugs one called tamoxifen can reduce the risk for breast cancer by about 50%. Also, oral contraceptives can decrease the risk for ovarian cancer. And also surgeries like bilateral mastectomy or risk-reducing removals of the ovaries can be done, depending on the situation and depending on the person, what they may opt to do. We have a backlog of lots and lots of patients who we've been testing for years and years and years who have only been tested for BRCA1 and 2. And we, as a genetic counseling community, it's a big question out there. What do we do about going back to all of these cases and looking through their family histories and looking through everything and then going back and offering them a test that can look at all these other new genes? Because a lot of those genes on these like in the panel tests, may really change the outcome for these patients. But they weren't tested for a few years ago because it just wasn't it wasn't standard of care. And really maybe there weren't even guidelines for these genes, or maybe the genes were hardly even discovered at that time. So we couldn't test for them. So that's a big question in the genetic counseling community, is what do we do? How do we get these people to come back in? Because a lot of people are out there probably walking around with well, not a lot of people, but a lot of people that were evaluated initially for a BRCA mutation very well, especially if they have a strong family history, very well may have a gene mutation or a hereditary cause to their breast cancer that could be picked up today. And so, we're working on that. We're trying to have some people come back in who are particularly high risk, or have a particular concern about their family history, or have reevaluated with their doctor recently. So hopefully we'll be able to give them some answers. Ambry, in my experience, they've been really responsive and really attentive whenever I needed clarification of something on a test report. So going back to an example that I had earlier, this patient had a test result in one of the genes on the breast next panel that was in a gene that we know a little bit about, but there's just not a whole lot of information. There's not a whole lot of huge studies that have been done on people with those particular types of gene mutations, and there's not a whole lot of people that have been diagnosed with this in the past. So the benefit was that at Ambry, I was able to give a call to the customer service line, and they put me in touch with one of the genetic counselors, actually one of the genetic counselors who was part of developing putting together the literature and developing the test reports for the breast next panel. So she was really the most informed person in the genetic counseling community anyway that I could find at that moment, to give us an idea of what they've seen on the breast next panels that have gone through, what kind of results have looked like the one that we got, and what did that mean for the other families that they had seen. And so she could walk me through what they've already seen, what they've learned since doing this test, and what it might mean for my patient, and what we may be able to give my patient as a little bit of extra information. So I felt like they were able to give me really the most up-to-date and current information. By talking to a genetic counselor, you kind of feel like you're talking to somebody who understands the same perspective that you have and understands the same need that the need for information that your patient has, and puts it in a way that you can explain it back to the patient very easily.